Everybody, and thank you for coming. My name is Melissa Witham, and I work with the Opioid Response Network and C4 Innovations. And today is the second in our three-part series on providing support to people in recovery who are at end of life. Today we'll be talking about the final stages of life's journey. And with us we have Diane Snyder-Cohen and Kristen Martin. I'm going to take just a minute to tell you a little bit more about the Opioid Response Network and to let you know that we have live phone lines today. So that means that we will be taking questions and comments from you all both verbally as well as in the questions and comments chat box on the screen. The Opioid Response Network is a SAMHSA-funded technical assistance center, and we assist granted organizations, individuals, and other organizations who support people who are in recovery from opioid use disorder and as well seeking treatment or prevention services. And the Opioid Response Network works across the United States. They take requests for training and education and resources around prevention, treatment, and recovery. Each state has a designated technology transfer specialist who will go over your individual organization's needs and provide subject matter guidance to you and your staff. And for more information on the Opioid Response Network, you can visit our website or give us a call or email us at orn@aaap.org. I'm very happy to introduce you to Kristen Martin, and she will get us started.
Hello, my name is Kristen Martin, and I'm a licensed marriage and family therapist. Currently, I am the program administrator for early childhood mental health at the Department of Public Health, and I supervise various programs there. I'm over the CCHC, all the early childhood mental health specialists in the state, Help Me Grow Kentucky, the Connect the Dots curriculum, Kentucky Strengthening Families curriculum, as well as the HEART program. And that program stands for Healing, Empowering, and Recovering Together. We have a team in Floyd County. That's our first pilot site of peer support specialists, social workers, hands home visitors, and early childhood mental health specialists that work with mothers who are in recovery and they're currently pregnant or have a child up to 2 years of age. And so we have a wraparound program that helps keep babies and moms together while providing education on how to best work with their child. So the day starts out with education on parenting and milestones that your child will be going through or should be hitting, and then the day ends with peer support. So that is a little bit about that program, and the reason why I'm connected today is previously before that role, I was a bereavement counselor for several years with the local hospice agency in Lexington, Kentucky, and that is called Bluegrass Care Navigators. So I was a part of the hospice team and served as the bereavement counselor role on that team. And I worked with families who had someone that was actively dying, and then worked with the family after the death as well to process their grief afterwards. And I will allow Diane to get started with her introduction.
Diane, I think you're muted.
That's pretty funny. Hello, I'll try this take two. So welcome everyone. I'm so glad that some of you are back with us and some of you are here for the first time. I'm Diane Snyder-Cohen. I am the Director of Western Reserve Grief Services of Hospice of the Western Reserve. We are a large not-for-profit hospice in Northern Ohio. I've been there, I'm going on my 19th year. I oversee the community bereavement program and the hospice bereavement program. I oversee the art and music therapy program. I am in charge of the spiritual care education program and a few other programs. I have been involved with the Opioid Recovery Network doing presentations on grief and loss, I am the leader for the bereavement professional section for the National Hospice and Palliative Care Organization, which serves the entire country, and I'm part of their opioid, they call it bereavement after an opioid death work group, and also their trauma-informed care work group. So that's just a little bit about me. So today, in the first webinar, we talked about supporting someone who's actively dying. And we talked about how to increase your comfort level. We talked about empathy and the differences between empathy and sympathy. We talked about active listening, end-of-life conversations, advanced directives, ethical wills, and trauma-informed care. Today, we're going to talk about the physical signs and symptoms as well as some of the emotional and spiritual challenges that occur during the final days. Now, we're talking about days, like the last 7 days. Could be a little longer, could be a little shorter, but that's what we're talking about here. And we want to talk about how we can support people during those last days. This is a view of Lake Erie. It's from outside our inpatient unit. We have an inpatient unit on the lake. So everyone's life journey is unique, and so is the journey towards death. So we know that this is a difficult time because people don't know what to expect. And we hope that this information and knowledge will be helpful to you, but even with this knowledge, it might be a little bit unsettling and uncomfortable. And so we want you to be kind and gentle with yourself as we go through the next few slides, because they might be a trigger for you. Hospice teams, if your person is lucky enough to be involved with a hospice, and I would encourage if it's the last days of life to be involved with a hospice, their goal is to preserve dignity and respect. Now, dignity means many things to many people. It's about self-respect, family, friends, what people value, all the things that make the person unique and special in their life journey. Comfort is what we offer when a person is having symptoms. And these can be physical symptoms like pain, but also breathing, constipation, nausea, weakness. All those things are symptoms. So hospices promote dignity and symptom control. Now, we don't want you to experience compassion fatigue while you're sitting with a person who is dying, so we want you to take care of yourself. And in our final session, we'll be talking more about self-care, but there is, compassion fatigue and vicarious trauma, and we want you to be aware of yourself so that you don't experience that. So at this time, in the chat box, if you're currently caring for someone who's seriously ill, can you put that in the chat box, please? I know some of you mentioned that you have in the past year cared for someone who's seriously ill, whether it's a relative or a child or an adult that you're caring for, or if it's somebody that you're working with as a peer support specialist. We would like to know who you're currently working with. All right, so it looks like then that we don't have many comments in there, so I'm guessing no one currently is working with anyone. And that's okay. We just wanted to get a sense of what was happening. So months before the death, it's not uncommon for the dying person's world to turn inward. There's a shift away from the more social world. Perhaps there's inner work to be done. You and the patient might be wondering what the meaning of life is, what the purpose of life is. This might be a time to ask for forgiveness, express feelings of guilt or lack of trust. It also could be a time to reminisce and share stories, and we talked about that last time. But it also might be a time for closure and resolution. In the 10 years since Ira Byock published his book, Four Things That Matter Most, this has changed. These 4 phrases have changed the lives of thousands and thousands of people. And we can practice these life-affirming words in our day-to-day lives, and it can improve our relationships. There's a value in stating the obvious. There's a value in letting someone you love know that you love them. And there's benefits of letting old grudges and toxic emotions. So all these things are important. In our agency, we have over 6,000 deaths a year. We're a big organization, so we have lots of deaths every day, every year. So it's a few hundred every month. So we encourage families to use these 4 phrases. They have been found to ease suffering and provide a peaceful ending. Not always, though. I don't want you to think that if you're working with someone and they go through these phrases that they're going to have this beautiful, hospice, peaceful death. It doesn't always work that way, but they can. The 4 things are about completing relationships and reconciling strained relationships. So completion means that there's nothing left unsaid or undone. And while this can be difficult, it can bring peace. It could be a time of openness. It could be a time where you feel relief. And your greatest gift is to be present. Now, Kristen talked about presence last time. I'm talking about presence now, and we'll be talking about presence again and again and again, because it truly is your greatest gift. Both my parents were in hospice. My dad was in hospice for about 8 hours, and my mom was in hospice for several weeks. So my dad was in the hospital suddenly. He had been sick for a while, but all of a sudden there was an event. So he was in the hospital, and he went from the hospital into the inpatient unit. And he was literally pushing away at death's door. I don't know what he was seeing or thinking, but he was pushing. He wasn't really verbal at that point. And all the nurses were around us saying, well, did you say what you needed to say? Did you say goodbye? Did you say whatever it was that you needed to say? And I'm 1 of 5, and we're all looking at each other. It's like, yes, we've said these things over and over the past several months. And so we had each of our children call. We contacted his brother in San Francisco, and this was very funny because his brother was going, my dad's name was Marv, going, Marv, Marv, and all of a sudden my dad, who's like curled up in a ball but pushing, turned around and said, Leonard, I hear you. And we all just started giggling. It was really quite funny. And then he settled back down, and he was still agitated, but with medication he settled down. And we'll talk about agitation in a little bit. But the nursing staff was really trying everyone to say what they needed to say. With my mother, well, I must have, full disclosure, I was not the most wonderful adolescent, and so there was lots of drama in my growing up years, and so I was apologizing to my mother. And my mother was sick for probably the last 7 months of her life, and I would apologize. I'm so sorry for all the things that I did when I was an adolescent. I'm so sorry, I'm so sorry, I'm so sorry. And every few days I would apologize all over again because that's what you do at the end of life. And she finally looked at me and said, when are you going to stop apologizing? And I looked at her and I said, when you forgive me. And so she said, I forgive you. And I said, okay then. And we never talked about it. And a couple of weeks later, she did pass away peacefully. And it was a beautiful experience surrounding her because she was not pushing away. She was very ready to die. So that's my little story. And I've seen so many stories of people where these people have come, strange family members have come back, and sometimes it's not so wonderful, and people die how they live. So the spiritual care coordinator said to me when my dad was dying and pushing away, he goes, well, is your dad a fighter in his life? And I was like, yeah, he was a fighter. And so she said, well, he's dying how he lived. And so that was an important thing for me, even though I've been working in the field for so many years, something that I had to remember. So these 4 phrases, please forgive me, I forgive you, thank you, I love you. I would like to invite anyone who would like to speak up to mention how these phrases impact them today in their lives and how they think they could impact them working with a loved one or with a patient that you're assigned to during their final days. What do you think about these 4 phrases? Well, think about them because they're really things that you can use every single day. You don't have to wait until the last few days of life, especially the please forgive me, I forgive you. I'm going to move on, and if you think of something, we can always talk about it later. As the patient is preparing to die, again, he or she is going to turn inward. And this is a withdrawal. This is not a withdrawal of love, but it's the need to focus energy and attention inward. We don't know what's going on in there, but there could be a lot of stuff going on in there. And so again, the greatest gift that you can give is your gift of self, your gift of presence. You can position for comfort. You could fluff a pillow. You could apply a cool compress. All those things can provide comfort, and they're a lovely thing to do. So these simple, tender gestures provide meaning and grace and dignity in the final journey. And everyone reacts to the dying process in his or her own way. There's some common emotions that you'll feel as a peer support specialist, and you might feel overwhelmed. But remember that these are normal experiences to have, and take time to take care of yourself. You have to replenish your well. You cannot care for someone in their final days if you are not caring for yourself. And that's very important, and a lot of people forget about that. They want to just sit vigil, but they still need to spend time for themselves so that they can be present for the other person. We'll talk more about self-care in webinar 3, but it's something important to think about. Grief. We talked a little bit about grief last week with anticipatory grief, and we're going to talk all about grief next time. But grief plays an active role during the final days. There's an active role of grief in the dying process. You have to remember that grief is unique as a fingerprint. There's no calendar, there's no timetable, there's no race to the finish line. You can have feelings of denial and anger and relief and fear and abandonment and confusion, or none of those. You can have all of those or none of those. Many of us are aware that grief is a normal part that we experience when there's a loss, but it doesn't just occur after the loss. Anticipatory grief, which we referenced when we were talking about legacy work last time, is the form of grief that occurs when one is confronted with a life-threatening or chronic illness or actively dying. And if I'm the person who's actively dying, I could be feeling anticipatory grief, and if you're the person caring for someone, you can be experiencing anticipatory grief. And it doesn't necessarily lessen the grief after the death. It's not grief pushed ahead. So it is a time to complete things that are left unsaid or undone, but it's a response to the loss of the person who is ill and the caregivers who are close to them. So everyone's going to experience more anticipatory grief in their own unique way, and we'll talk more about that. When we think of grief, we often think of just the death of a person, but there's all these secondary losses that come with grief that we need to pay attention to. So there's the tangible loss when people have a loss. So they might if you might experience the loss of a job or a loss of an income or your loss of your home, or if you're in a horrible accident, you may lose the loss of your arm. And when you're dying, and as you're dying, you're having losses along the way, loss of energy, loss of functioning. You also have intangible losses, the loss of future hopes and dreams. Those are called secondary losses. So these losses that people are experiencing while somebody is dying is not just the grief in the moment, but there's these future losses and these secondary losses that occur over time. We want you to just accept that anticipatory grief is part of the process and acknowledge the loss. And you can use the word loss when you're sitting by the bedside with a person. Lots of people are afraid of words like death or dying or grief or loss, but these are okay words to say during these times. Gee, these are a lot of losses happening at the same time is something that you can say. Boy, that loss is really hard, so-and-so. You can't do this anymore. That must be hard for you. And so it's important that you also stay connected with your support person. So as a peer support specialist or as any kind of a person who's sitting with somebody who's dying, remember the self-care and seeking supervision when you need to. So there's no rules to grief. Grieving is unique for each person, and the way to get through it is unique for each person, and we'll talk about that more next time. There's some deep feelings that are held by both the patient who is dying and you, the peer support specialist. So these feelings of deep sadness may seem overwhelming and uncontrollable. And they're natural responses to the dying process. You might be crying, you might be agitated, the patient might be crying and concerned. And we just want to tease out the differences between grief and depression because they could really mimic one another. And grief is normal, but depression can become serious. So signs of depression would be a lack of motivation or interest in things that you're no longer interested in, feelings of worthlessness, excessive guilt or suicidal thoughts. And sometimes people feel guilty when their person is dying that they did the wrong thing or didn't say the right thing. That's guilt around a specific thing that sometimes you can talk through and explore. But this excessive feeling of guilt and worthlessness and helplessness, that's more of a depressive sign. So we need to weed that out. Also, if there's using substances or self-destructive or acting out behaviors, those would also be
Line muted.
is taking over, and that needs to be looked at. And then there's the feelings of anxiousness, and lots of people feel anxious at this time as well. You know, worries might intrude on your sleep, and sleep might be a problem for you, and you want to share your worries with your supervisor or with the hospice team or whoever is around that can help you sort through these things. Some people feel like they're really going crazy at this time. They may have these strong feelings of fear and doom and disaster, and they even feel, I know it sounds so dramatic, but people have these feelings going through their head, and we want to just let them know that these are normal reactions to this dying process. But they also, again, can signal an anxiety disorder if there happens to be an underlying one, or perhaps the person has a previous one. So you need to be aware of that. So panic disorder is an example of an anxiety disorder, and there's a number of physical and emotional symptoms that can occur with that. And they're pretty strong, and we really want to make sure that people do not experience panic attacks or severe anxiety or depression. So it's really important to listen to your gut, listen to your inner voice and your intuition, and seek help for yourself if you need it. And if you're recognizing these kind of symptoms in the person who is dying, then you can bring that to somebody's attention. But I don't think you would see those symptoms in the final days of the dying patient. More so you might see them in yourself, because the patient might be anxious and worried about dying, but during these final days they might not have that many of those symptoms. Well, now we're going to move to physical signs and symptoms approaching death. And the first one is the decreased need for food and drink. Before we go into this, and Kristen's going to cover a lot more of these physical signs and symptoms as well, there's going to be physical changes taking place, but not all of these signs and symptoms that we share with you today will appear. Not all of them will appear, but some of them might appear, and some of them might appear at the same time. So if there's a medical team involved, they can help you as the patient is changing and how you can support him and yourself during this difficult time. So the first one is this decreased need for food and drink, and that's because the body is slowing down. The person's not going to experience hunger, as the body has its own wisdom of what it needs, and there may be difficulty swallowing, and the mouth will become dry and need to be kept moist. So on this slide, you can see what can help. And so cleaning the mouth with toothpaste or a soft toothbrush, or they have little toothettes, which are little styrofoam things. I don't know if they're styrofoams, but they're like a soft, spongy thing at the end. Hard candy, ice chips, frequent sips of water. My mother lived on a spoonful of chocolate ice cream mixed with raspberry sorbet for the last several days of her mouth. You can put lip balm on. So those are things that could help. But I want to talk a little bit more about food and fluids, because this is a hard thing for our culture, is to not want to feed somebody. We like to feed people. We want to make sure there's enough food at the table when we invite people over. And when people are at the end of life, lots of times caregivers, even nursing staff and places feel like, oh, the person will just give them a sip of water or a little bit of food. They think it's a good thing. But sometimes the person could choke or aspirate, and so that's not a good thing. And some people have no food or fluids included in their advance directives, and we need to honor that. And if there's a doctor's order, nothing by mouth, then there's nothing by mouth. And one of my many roles is chair of the ethics committee here in our organization, and lots of times we've had people who struggle with this because they think that they need to give a sip of water or a something or food. And it's not what the person might want, and it's not in their, there's a medical order not to, or it's in their advance directives not to, and we need to honor that. So if there is a hospice team involved, they can help you honor the patient's wishes, and it's important to do that as hard as it might be, remembering that this is their choices, this is the way they want to have in their life, not what you want to do. And also it's the body's way of just naturally slowing down. There's not a need for that. Another thing to think about, and while it's rare, is a process called VSED, V-S-E-D, which is voluntarily stopping eating and drinking. And some people choose to do this. It's not a natural part, it's a natural part of the dying process to not want food or fluids, but some people who are not in that last stage of dying choose to stop eating or drinking, thinking that that will help hasten death. And it will, but it could take a few weeks to do that, and it's a very hard thing to do. Again, if your person is part of a hospice team, there's probably a practice regarding VSED, and if you have questions about that, I'm happy to talk with you about them. And you might be just wondering about swallowing pills, because there's going to be a less need for medication during these last days, but there might be a need for pain medication and certain medications. So pain medication is often crushed and diluted with a little bit of water if a person can't swallow, and then put with a little dropper into the side of the cheek, and just kind of works that way. And you would not be giving medication. Only a member of the hospice team, a nurse, or a family would be able to give medication. But it's really important to continue to give medications as they're prescribed, because once a person is calm and settled, you want them to remain comfortable. The person is also going to be spending more time sleeping, like multiple hours a day. Could be 18, 20 hours a day. That's not uncommon. And that's a result of the body's metabolism slowing down. As a peer support specialist or as a family member, you want to spend the time that they're awake being engaged with them. So whenever they're awake, you want to be awake with them and have your conversations during those hours. A few more signs and symptoms before I pass it on off to Kristen. One is incontinence. So incontinence of urine and of bowel might occur. Your hospice or nursing aide can help you obtain pads to put underneath your loved one so there's more comfort. There might be a decrease in the amount of urine, and it might be darker in color. That's to be expected because the kidneys and the intestinal organs and all that stuff is slowing down. Sometimes a catheter is put into place, but again, these pads underneath will help keep the dying patient more comfortable. The last thing you want is the skin to break down, to have open wounds or sores. They're terribly painful, and you really want to avoid that if you can. So most places will be checking the skin every day or moving a patient so that they won't get any sort of sores like that. Clarity of hearing and vision might change. You want to keep a soft light on in their room. You want to assume that the person can hear. They say that hearing is the last to go, so even in the final moments, if a person is not responsive, they can still hear your voice. So you want to speak in gentle tones with readings. If we have time, towards the end, I have a few readings that I can share with you. And you want to explain what you're doing. So if you're shifting them or getting them a blanket or whatever it is that you're doing, you need to talk to them and let them know what you're doing, not just go do something to them. The arms and skin might be bluish to the touch. They might become mottled. You might have a redness on the palms of their hand or their feet. You might notice that the body is somewhat cool or bluish in color, and again, that's a result of the blood in the circulation just slowing down. And even though they feel cool, they might not be cold, but you can put a blanket over them, and then if they feel warm, you would respond to that as well. They might have a fever, but probably not. There's a dryness to their eyes, there could be muscle twitching, there could be all different things that are happening, and this is just a sign that the body is changing and slowing down. When the nursing assistant was there with my mom at the end of life, and she was wanting to give her a bath, she said that lots of times at the very last day there'll be a single tear going down their eye, and so she wanted to give her a bath the last day, or the second to the last day, and she said she saw a tear, and I was like, I don't think she's going to go today. But on the very last day, when we were giving her a bed bath, not a bath, in a bathtub, of course. And we turned her, and she did have a single tear coming down, and the nursing assistant had said that was an angel's kiss. And so my mom did have that, and the thought was that within 12 hours after that kiss, the person would die, and my mom did pass away that day. So that was just a lovely feeling for us to experience. All right, so I am going to pass it on to Kristen now. Here you go, Kristen.
Thank you. And some of the things that Diane discussed, we'll just hit on just a little bit more briefly because we're still on physical signs and symptoms, of course. But restlessness can be a part of the dying process. And it's really common for a person to become restless and even pull at their bed linens or maybe their clothing. And restlessness does not necessarily mean that pain is present for the person. Restlessness can be difficult for caregivers and other people that care about the person to manage, since it is difficult to see the person that you love uncomfortable or appearing to be uncomfortable even if they're not feeling that way. Even mild-mannered individuals may suddenly become extremely agitated, making angry accusations to their caregivers. And the dying person may even demand to get up or want to call the police or call an ambulance. Their body may jerk or twitch, or they may even pull things like their bedding and clothing, as we mentioned before. And if the patient is experiencing terminal restlessness due to pain or another treatable condition or cause, the hospice team will treat this first. And if there is no treatable symptom, the best course of action is to try to calm the individual and keep them safe. So these things can include adding side rails to the patient's bed to prevent them from getting up. And family caregivers can help their loved one by spending more time with them, staying by their side, and keeping them from getting up or accidentally harming themselves. It's important to offer reassurance and a calming presence. We say that so often because it is so important. By reading favorite stories or prayers, anything that you think they may enjoy. It can also help to play soothing music. And then, of course, with permission, you may even be able to hold the person's hand or just gently rub their hand. You could also pat their shoulder or gently brush their arms. And in order to maintain a calm environment, sometimes it is helpful to decrease the number of visitors. And this can be really hard for family members. I know specifically for my role, sometimes I would come in and work with the family on helping them understand that when you have a lot of people in a small room that have really big personalities, that can be really hard for a dying person to manage. And so advocating for the patient and helping the family understand that that's just too chaotic for the person. So having people come and visit in shifts. Or even if all the family want to stay at the home for a long period of time, maybe they need to take breaks outside of the room that the dying person is in. The dying person may also become increasingly confused about time, place, and even the identity of very close and familiar people. So again, offer that reassurance to the person. It's important to remind them what day it is, what time it is, and even who's in the room with them. These things can help comfort them and make them feel a little less confused. Soft music and dim lights can also be calming. And then also reminding yourself to identify yourself by name before you speak. Speak normally, clearly, and truthfully. So like Diane mentioned, you can explain things like what you're doing instead of just doing it to the person. So for example, saying something like, it's time to take your medicine now, and then explaining why you need them to do that. So saying something like, so you won't start to hurt, or your pain won't come back, or you will remain restless, or you'll remain calm and not restless. It's important for you to have patience and stay calm. These situations can be really nerve-wracking or anxiety-provoking. So just maintaining your temperament and keeping yourself calm is really important. And again, just like we've mentioned many times before, your presence and just being near is very, very important. All right, breathing. The patient may have moist-sounding breathing. When relaxed vocal cords and a small amount of oral secretions collecting in the back of your throat cause this, the patient doesn't feel any discomfort from this, and they may not even be aware of it happening. However, this sound can be very uncomfortable or disturbing to family members and other caregivers. I know that my sister, she has like a surrogate grandmother. Our grandparents, the majority of them were deceased before we were old enough to get to know them, and her best friend, her grandmother was like her second grandmother. And she sat at her bedside in the last, honestly, week of her life. And I remember my sister calling me constantly in those last few days of life because she heard that breathing and she couldn't stop thinking about it. And even to this day, when she talks about, she calls her Nana, she says, gosh, I just can't get that sound out of my mind. It just bothered me so much to hear her. And so what I try to do is just normalize that for her. It is really disturbing to hear that sound. But just remember, you know, Nana wasn't in pain. It's just disturbing for us to hear, but she wasn't in pain whenever she was making that noise. So just educating family members and friends about what's happening can be really helpful, because that's the worst thing we can think of, is that our person is uncomfortable at the end of their life. So you can notice a change in their breathing patterns as well. So the person may take shallow breaths with periods of no breathing for a few seconds to even a minute. They may experience periods of rapid, shallow panting, and these patterns are common and indicate just a decrease in circulation. Elevating the head of the bed or turning the patient on their side will usually quiet these breathing sounds. Hold their hand with permission and speak gently. And there can be 10 to 30 second periods of no breathing, referred to as apnea. This symptom is very common and can occur at the final stage of life. Pain. So Deborah Whiting-Little wrote in the Family Handbook of Hospice Care that the control of pain is really the heart of terminal care. People do not fear death so much as they fear unrelieved pain and being alone with their suffering. Many terminally ill patients experience physical pain or discomfort. Physical pain is our body's internal regulatory system alerting us that something is wrong. There are some signs that tell you that a dying person is uncomfortable physically or is in pain. The person may be shifting around in bed, trying to get comfortable, or maybe they even scrunch up their face in a grimace, or maybe their limbs contract into a muscle spasm. These are just some signals and signs that they're experiencing pain. The fear of pain can occupy much of a patient's thoughts. It can also bring about emotional stress and tension, which can prevent pain medications from working properly. The focus is always to offer optimal pain control and to also reassure the patient that their pain will be managed. The goal of pain management is to relieve and prevent pain from reoccurring. Pain and discomfort may diminish as death approaches. Also, the patient may not even appear to be in pain. There may also be moaning sounds, which don't also necessarily signify pain. To ensure effective pain management, continue to give the medications as prescribed by the doctor. Trust the medical professional to prescribe the correct medications at end of life. Honor the prescribed medication by the doctor and give the medication as directed to avoid pain and other complications. Providing gentle touch with permission can also help with pain. You could offer to rub lotion on the person's hands, or guided imagery can also be very helpful. Imagery exercises use creative imagination to picture scenarios that relax and heal. You can guide the person through envisioning a relaxing scene. A common relaxation practice is to mentally picture yourself in a pleasant place that puts your mind and body at ease. For example, imagine yourself lying on the beach with the sun shining, listening to the waves. It is important to imagine a place that has a positive association for you. So, for example, a beach or the ocean may not be a very pleasant sight, or it might be a trigger to an unpleasant memory. And a great example I have of that is I worked with a young spouse that his wife had just died, and they had a young child, like 3 years old. And right before his wife got sick and died suddenly, they had just taken this amazing trip to the beach. And so when I brought up imagery, that was one thing that he definitely did not want to focus on, because it triggered, even though those memories were very happy, he was not ready to focus on those yet. And it was too painful to think about having her there and now not having her in his life now. So helping the person think about what is peaceful to them and not just making assumptions on what a good scene or experience could be. In addition to physical pain, a patient might experience emotional, psychological, financial, or spiritual pain. Hospice care includes social workers, spiritual care providers, and other professionals to help patients and families talk about their fears, anger, and grief, as well as alleviate emotional and spiritual pain. Nearing death awareness. In the final hours, days, or weeks, your loved one may make statements or gestures that seem to make no sense to you. They may have visions of people and things you cannot see. Nearing death awareness often includes visions of loved ones or spiritual things. The visioning is often comforting. Your loved one may use metaphors such as preparing to go on a trip or a journey. Keep an open mind and listen carefully to underlying messages. You may even find these images or scenes very comforting as well. The dying will often say things like, "I want to go home," even if they are already in their home. This can mean that they want to leave their physical body. They're all done suffering and they want to move on to whatever dimension or realm that they believe follows this physical life. It can be disturbing to hear this over and over again, especially if you were the one caring for the person in their own home. The person may also, like we mentioned before, try to start getting out of bed or saying that they need to leave now and go home. This can be unsafe because usually at this point they can't stand on their own. So instead of like saying things like, no, you have to stay in bed, don't get up, you can just place your hand 3 to 6 inches above the person's shoulder so that they encounter your hand as they get up. This usually stops them from pushing further with their desire to get up. And if they continue to keep, or they're demanding and continue to keep thrashing up to try to get up, ask for medications to calm them down so they don't hurt themselves. You can also say things like, you have a choice to leave your body at any time, or saying something like, it's okay to go. It's just reassuring the person that they can leave their body at any time. You can reassure them that whatever they may be troubled by, either a concern for their spouse or child or with their own unresolved conflicts, that they can trust that all will be well and they can let go of this life in peace. Emotional and physical support. So the main goal is to keep the person comforted. That's physically and emotionally. So we want to shift our mindset to keeping them comfortable, not helping them get better. We want to help them experience a peaceful death or death without pain if possible. And as we mentioned in the first webinar, it's really important to ask the person what their wishes are. So as we previously talked about, asking them if they want to die at home in hospice care, surrounded by family and friends, or seeing if they want to die in the hospital being treated by a team for their illness up until the final days of their life. Or do they want to die alone? All of these options are okay and allowed. It's not for us to decide what's best for the person, even though that can be very tempting to give your 2 cents. We want to work to prevent suffering and pain, as well as improve the quality of life. So focus being fully present with the person. Provide physical contact if wanted by holding hands, offering a brushing touch on the person's arms, or gently rub the person's hands or shoulder after getting permission, of course. These gestures can help the person feel comforted and soothed. Work to create a comforting atmosphere for that person. So it's very important to know their likes and dislikes. You can do things such as playing their favorite music, saying prayers, offering soft lighting, comforting smells, having lots of family and friends around versus only having a few family and friends. These are all great ideas and places to start. Spiritual support. Provide an opportunity to make amends and resolve conflict. Talking to someone from his or her own spiritual community can help, such as a priest, minister, or rabbi. The dying can find comfort in their faith. This may also be a time when they are struggling with their faith, and that's okay. This just provides an opportunity to process these feelings if they want to. If the dying person is receiving hospice care, they can talk to a chaplain or a counselor. It can be helpful to have a person outside of the immediate family to process thoughts and feelings with. I know for our hospice team here in Lexington, there was a fabulous story that happened once on our team that the person, her mother was dying, and she just was really not open to talking with a chaplain or counselor. She just didn't feel comfortable doing that, but had gotten really close with the nurse. And when her mom died, she sat outside on the front steps of the house and just sobbed and talked with the nurse for a few hours. And so the hospice team is trained and able to have conversations like this, and we really just try to meet the family where they're at. So we didn't try to force her to see a counselor or chaplain. We just let our nurse take the lead because they had the best rapport and relationship with one another. Offer to pray or read spiritual readings if the person is religious. And you could also listen to the person's favorite hymns or other religious music. Share your favorite memories with the dying person and share why they are important to you. So family and friends could talk to the dying person about the importance of their relationship. So for example, adult children can share how their father has influenced the course of their lives, or grandchildren can let their grandfather know how much he's meant to them. Friends can relate how they value years of support and companionship. Family and friends who can't be present could send a recording of what they would like to say or a letter to be read out loud. I know on our teams, a lot of the times people use Skype or FaceTime since we have all those technological advances now. Even if you couldn't travel quickly to be at the bedside, you could still have that face-to-face interaction with the person, which is wonderful. So sharing memories of good times is another way that people find peace near death. This can be comforting for everyone. And then most doctors say that even when the patient is unconscious, he or she may still be able to hear. Therefore, it's probably never too late to share how you feel or to share fond memories with the person. Always talk to, not about the person who is dying. And then music therapy can also be comforting at this time if it is an available resource. So supporting family members. Elizabeth Kubler-Ross explains the importance of people participating in their loved one's death process in the Family Handbook of Hospice Care by stating, when someone dies, it is important that those close to him participate in the process. It will help them in their grief, and it will help them face their own death more easily. So it's really important to ask family members how they are doing. And then also ask if they need someone to talk to. This is one of my favorite ones because we all offer just, let me know if you need any help. But that's not specific, and most of the time people don't take us up on that, myself included, when people say those things to me. But if you specifically say what you're willing to help with, the person is more eager or willing to accept that help. So saying things like, how about I walk the dog for you today? Or let me go grab you all some groceries. All of those things are helpful, specific suggestions instead of just making that blanket statement. Offer respite when possible. So saying something like, you know, everyone needs a break. How about I stay here for a few hours while you're away? And really encouraging the person to take you up on that. Because it's true, everyone does need a break. You could also help them coordinate visits from family, since this can be really overwhelming to try to keep up with and coordinate. Be fully present and not afraid to talk about their thoughts, feelings, and concerns. And then if you're sitting with a dying person, really make sure you're doing a good job of taking care of yourself as well. This can be really exhausting emotionally and emotionally draining. Try to adequately hydrate yourself, eat, and get rest. right, so we'll end with a quote here. The best and most beautiful things in the world cannot be seen or even touched. They must be touched with the heart. You are giving your loved one the greatest gift you can by being at their bedside. This can be emotionally, physically, and spiritually draining, but it can also be the most profound and intimate of all the experiences you may have in life. So thank you for your time, and I'm going to shift back over to Diane, and she's going to lead with questions from the audience.
So thanks, Kristen. Please post your questions in the chat box, or you can just speak up. I believe everybody's unmuted. While you're thinking of your questions, I just want to share, I walked past a colleague's door the other
Line unmuted.
door. It's by Dr. Rosalie Shaw. Oh, do you have a question? Okay, I'll read this while you're thinking of your questions. It is a privilege to do this work that touches deeply into the mystery of what it means to be human, what it means to live for this brief span, to suffer and die. Symptom management is important, but the relationship we establish with the patient is more important. Symptom management is doing, is what we do. Communication is being, how we bear witness to suffering, by listening, by showing respect and kindness. There must be the intention to be present, to create a bubble of attention, putting aside assumptions and our desire to fix things. This is the person's time, even if it is only a few minutes of time. So I think that just speaks to the importance of being present and giving that gift and setting that intention that this is what you're going to do. You're being present to that person. So are there any questions or thoughts or concerns, things that you were surprised by, things that you've noticed in people that you've sat by the bedside with?
Hi, this is Edward Porter. Can you hear me?
Yes,
We can.
Oh, hi. I've been participating by phone only this time. I did want to say this has been very helpful for me because my mother has Parkinson's, and she's had it for years, and it's getting worse and worse. And so it's been very helpful. I am getting some of that anticipatory grieving that y'all talked about. So I just wanted to mention it's been helpful for me. And also for my work, I do peer support for life skills on the ACT team here in Bowling Green.
Thank you for sharing that. You know, with Parkinson's disease, that's a hard disease because there's losses over a continuum. You just adjust to one loss and you figure that one out, and then there could be another loss, and then down the road there's another loss. So it takes a lot of hard work and compassion, and thank you for being her caregiver. That's a wonderful gift that you're giving, and I'm glad that these things are resonating with you. We'll be talking more about grief next week, so I hope that you'll join us.
I plan to. Thank you.
Thank you. Other thoughts or questions? When Kristen was talking about nearing death awareness, I was thinking about the time I sat with my neighbor whose mother-in-law she was caring for was dying, and she was just sitting in a chair because sitting was easier for her breathing, and she was not kind of nodding out like this, and about every 20 minutes she would go like this and say, "I'm not quite ready, I have to get my sweatshirt," and then she'd go back down. And we don't know who she was talking to. I mean, she was looking up. We could only imagine. And she did this every 20 minutes to a half hour. And we just watched her. And I went back the next morning. As I said, she was my neighbor. And she had died through the night. And my friend Laura, who was the caregiver, said to me, "God was in my house last night." I said, okay. So it was just a beautiful thing, and it was just so interesting to watch. My mother was waiting. She needed her yellow raincoat and her suitcase because she had to catch a plane. And so she kept on having, just preparing to go on a trip. And we hear it so many times in hospice with boats and trains and planes and getting their luggage and getting their clothes ready. It's a kind of common thing that happens. Other thoughts or questions? I know that there were a few of you that were on the call last time that were caring for a loved one that was in hospice. Do any of these things sound familiar to you? Did you experience that with your special person? Okay, not a chatty group. That's okay. I know it's a lot of information to
It's a
take in
Friday,
process.
Diane. Everyone's
Yes.
tired, and they're processing all their information.
They're processing. It's a lot to wrap your head around. We know that. We know we're very aware of that. So you have the PowerPoint slides, and you could reference them in the future or any time. They're available to you. And if you have questions, you can always reach out to both Kristen or myself,
Mm-hmm.
and we'll be able to answer any questions you have and support you.
Mm-hmm.
Well, thank you.
Oh, I see that someone named Joyil, it's a beautiful name, experienced several spiritual gifts during the loss of her grandmother, and it was quite beautiful. That's so nice. It can be such a beautiful, wonderful time, and that's what we're hoping for everybody. It's not always, but when it's beautiful, it's so lovely, and it's a great gift that you can carry with you.
Mm-hmm.
Well, thanks so much for listening. Oh,
We have our
Melanie,
last and final session, Understanding Grief and Loss and Self-Care, next week. So we really hope that you all tune in for that, since, like we've mentioned before, all the content just continues to build.
Thank you, everyone. And thanks for sharing in the chat box.
Thank you.